Let's start from the kind of most radical treatment for fibroids, which is a hysterectomy. That's often a lot of the times what doctors say, and I think part of that comes from some lack of experience. If it's not someone that focuses their career solely on managing fibroids, that's a really easy thing to do, but it's not nuanced, and it's not always respectful towards the patient's wishes, and it's not always the least invasive thing to do. So let's start with that big thing. What's another kind of lesser big thing that we can do, which is a myomectomy? Now, a myomectomy is just a fancy word for taking fibroids out. And fibroids can be taken out in many, many different ways. One of the ways which we've shunned taking fibroids out is I'm going to go on my chest here, making a big abdominal incision, opening up the belly either vertically or horizontally, and removing them, leaving you in the hospital for 3 days, putting you out of work for 6 weeks as a result of that. That's not what we do. That's almost never what's recommended. I can't remember the last time that we did one of those large surgeries. It's been years and years and years. Because if we have a difficult time doing it through tiny incisions, we can always get together as a team with the doctors at Maiden Lane Medical and take care of it together. So yeah, there's laparoscopic myomectomy, which is putting a couple of tiny holes in the abdominal wall and using instruments to remove the fibroids. That can be done with a regular laparoscopy. That can be done with a robotic assistance, which is our favorite way of doing it. But fibroids aren't always accessible through those tiny incisions. In fact, sometimes they're just, as Dr. Dada mentioned earlier, just inside the cavity of the uterus. So it doesn't make sense to then cut through the entire uterus just to get to the cavity, when we can access that cavity in a much more clean, much nicer, minimally invasive way, which is to do surgery through the vagina, in through the cervix, and then put the camera into the uterus and cut it out from the uterus that way. And that's an incisionless, easy in and out surgery that makes a lot of sense for a lot of women. Because we get a lot of referrals from infertility doctors, that's often the problem. And it's a very simple surgery for us to do. Sometimes in the office we can do that, and sometimes we take patients to the hospital for it, really depending on the size and what type of support we'll need for that surgery. So there are other minimally invasive things that certainly can be done. One of the minimally invasive approaches that patients frequently ask me about is uterine fibroid embolization. And I have to tell you that I'm a big fan of uterine fibroid embolization. And the reason I'm a big fan of it is because it's not surgery. And it generally comes with less predictable morbidity than surgery. There's no big, you get a little sedated, but there's no intubation. There's no big anesthesia task. Yeah, you're in the hospital overnight. So what? It's a procedure in which an interventional radiologist takes a small tube and puts it in the artery in your leg and moves it all the way up into the artery near your uterus and blocks the blood flow, uses little microbeads to block the blood flow to the fibroids in the uterus. It's a great therapy, and I really like it for stopping bleeding in women who have completed childbearing, in order to avoid surgery, so that you can stave off that time between symptoms and getting to menopause, which for most women will decrease or stop that bleeding altogether and significantly decrease the amount of symptoms they're having. Why did I emphasize women who have completed childbearing? Because there's a good body of data. And so no one wants to experiment on pregnant women, and pregnant women don't want to be experimented on, which is, well, on both sides is exactly how we want it. But so there's no good data on pregnancy outcomes with different anatomical variants of blood vessels around the uterus and fibroids. And the issue then becomes those microbeads go to two main places depending on the type of anatomy one has. They can go to the ovaries, and decrease the quality of ovulation, and they can go to the endometrium and decrease the quality of the blood flow to the endometrium, which, by the way, is where the embryo implants at the beginning of a pregnancy. And if your endometrium is bad news, that pregnancy is not going to hold. And if it's bad news because of an embolization, that's big trouble. So we try to avoid uterine fibroid embolizations in women who have not completed their childbearing. So usually that's generally reserved for older patients. All right. So are those the main? I know there are other techniques out there which we don't necessarily use here at Maiden Lane Medical. There are two other ones that are popular, and if you read them on the internet, they're certainly out there. One of them is called MRGFUS, which is magnetic resonance guided fibroid ultrasound. I'm pretty sure everyone's abandoned that technique at this point. Mainly the reason being that it takes like 6 hours on the MR scanner, getting blasted with ultrasound waves in the fibroid to just like melt a like 4 or 5 centimeter fibroid, and so that works for a very small subset of women with that like perfect smaller fibroid, but doesn't work for like 95% of women. The other one is fibroid ablation, which is a procedure done with basically an electrical wand that's placed laparoscopically and can potentially be placed under ultrasound guidance, but most commonly laparoscopically. And it's placed into the fibroid and basically burns the inside of the fibroid, right? And thus destroying the blood vessels around it, and then it kind of shrinks. So it's very similar to a uterine fibroid embolization, minus the microbeads that would go to your ovaries or endometrium. The downside of that is that you still have fibroids, and if bulk symptoms is a big problem, it certainly won't relieve those bulk symptoms quickly, and may make some pain worse, because there's a lot of inflammation associated with having that dead tissue sitting inside of your uterus.